said, you know, I would like to have counseling.
Yeah.
And it's true that whenever you have counseling in combination with methadone or could be nicotine replacement therapies or any of these things, you get way better results, and I'm sure it's because of the relationship with the person that you're working with that's facilitating that. And needle exchange programs, again, like there's one in Seattle, and we brought the guy in who was doing the needle exchange out in front of Tower Records in the University District where there are a lot of young drug users. We said, you know, what do you do out there exactly? He's got this card table out in front of the record store, and he says, well, of course I exchange needles, but also, he brings out this black book. He says, I got the names of people here where folks who are homeless or are from out of town need a place to stay tonight. I get them set up. I've got numbers of drug counselors here. And he had everything from what you might call harm reduction programs to abstinence-based programs, all available. And he said, you know, for some people that are new in town or whatever, I'm the person they go to when their friend died of an overdose and they need to get the message out to the community. I'm thinking this guy is a nexus point for providing all kinds of services that these kids otherwise are not going to show up for. Where else are they going to go? So he was very compassionate guy who was a former addict. He doesn't use anymore, but he doesn't sort of force that on people. Yeah. But it's available if you want it.
It has been my observation that this country has moved toward a punishment model right now. And you're raising the harm reduction, it sounds like a paradigm, an emerging paradigm.
Yeah.
And I'm wondering, how much do you think it will be successful in the climate of this country? Because the harm reduction model reminds me of Linda and Mark Sobel, who came just before you in this country and tried something like this, and that's why they're now in Canada, having escaped the sword of those people who are abstinence-oriented. So, this seems to be the full circle for me. How successful do you think the harm reduction paradigm will be in view of this punishment model that is dominating this country for the last 25 years?
By the war on drugs, you mean, that kind of model. By the way, Mark and Linda Sobel are back in the United States at Southeastern Nova University now. They're doing work on studying people who've recovered from alcohol and drug problems on their own without treatment. So they're still actively contributing to the field. Of course, the controlled drinking controversy, which the Sobels were associated with, trying to work with alcoholics to see if they could get them to drink in a safer way, caused huge controversies, especially in the early 80s when there was a lot of publicity about that particular study. And yet now there are lots of places, including where I'm working, where we're offering moderate drinking programs for like college student binge drinkers for whom abstinence is really not, for most of them, going to work. That's been accepted, even though it's, if I'm dealing with a 19-year-old fraternity man and he's drinking like 89% of his comrades in the house, it's illegal. This guy's an illegal drug use. He's not 21 yet. So I could say, hey, you're breaking the law, and we're going to try and work up a punitive approach that would expel people like you for breaking the law and so forth. Or I could say, if you've chosen to drink at this particular age, and you've gotten a DWI already and so forth, you need to come and do something about it. So hopefully we'll get you into a program that where either you could begin to reduce the harm of what you're doing and maybe even consider whether this is something you want to do at all. So I think, but you know, to get back to your question, there is evidence that needle exchange program saves lives. We had a big scientific review of the programs in order to present to Congress the evidence. Does this work? The evidence was, yes, it works. Donna Shalala, the Secretary of HEW, in the press conference says, we have data that needle exchange saves lives, but at the same time, we're not going to approve funding of it. So that's where the science and the data meet the policy, and there's a big clash. I'm not going to sit here and say that people in Washington, D.C. and the National Institute of Drug Abuse or this Center for Substance Abuse Treatment are going to come out in favor of harm reduction. They're not. They are against it. They think it's a movement for legalization. Somebody has branded harm reduction as a drug legalizing thing. You know, I'm working in alcohol. It's a legal drug. I mean, it doesn't really make a lot of sense, but There is an attempt to somehow stop the movement by branding it as a cover-up for people who want to make all drugs legal. I don't think that's at all what's happening, but that's what's being branded as.
And that's what I wanted to raise. I wanted to raise the issue that it is a problem, and your task is to satisfy the intense moralists in this country, who are very few, but because of their intensity, they're likely to succeed over this type of liberal, and it's going to break down into an argument between liberals versus conservatives.
I think you're right. Unfortunately, it's a public health perspective that we're talking about here. That harm reduction is a public health alternative between the disease model and the criminal justice war on drugs model. Zero tolerance, absolute abstinence. There's got to be something in between, because we're all different kinds of folks out here.
And we come from different cultures, and so many cultures, it's a part of their living to do things.
Yes, but that's really it's a good point, though, because it's really the moral condemnation of harm reduction that is causing the most political problems for any sort of implementation. Now, San Francisco just had a meeting on integrating harm reduction into traditional substance abuse treatment. Why? Because they're trying to have treatment on demand. They don't want to have waiting lists. They want to, this guy on the video signs up for a program, get him going right away. Not wait 8 months even to get methadone, because he may not, 9 months from now, be interested in doing that anymore. So they're having to do harm reduction, because if you want to do treatment on demand, you have to offer the whole spectrum of approaches. So, and yet, it's obviously still a big controversy about how to integrate these into traditional substance abuse abstinence programs, and that's still something that everybody's struggling with. But you're right.
It's interesting how it plays out in direct therapy, too, because I think that therapists generally recognize that when they're working with their clients, they need, but over the years, the myth has arisen that when you're working with a client with a substance issue, you have to put aside all the assumptions you have about therapy, and suddenly, in a mild-mannered, client-centered therapists suddenly are confronting people like they have to hit them over the heads in order to convince them of what they need to do.
That's right.
And your therapy with this client really showed that you could have a healthy client-therapist relationship.
Well, it's really just bringing the basic principles of psychotherapy into the substance abuse treatment field, because for some reason those two areas got split off, and with good reason. There were lots of people in the substance abuse field who felt that psychotherapists didn't know a damn thing about this, and they were not going to be doing any good. And that was, for a long time, that was true.
They were probably right.
But now, where we have more training, cross-training, or whatever you want to call it, in addictions and mental health, I think that's going to overall lead to more therapists beginning to integrate and to work with people with these kinds of problems in the way they would with any other kinds of problems.
Respectfully.
Respectfully.
Along the subject that we were just discussing about the differences between the zero tolerance and harm reduction, how would you work with a person, say a woman who has had her children taken from her because of drug use, and she hasn't yet gotten to the point of abstinence because she's not sure that it's causing any difficulty for her, except for the problem with DCFS. In order for her to regain custody of her children, she has to be abstinent.
Right.
So how do you specifically work with a client in that type of situation?
But to find out whether that's what she wants first. Because if she wanted it that much in the beginning and didn't stop using drugs, then her kids get taken away from her. Now she has no reason to quit, unless she decides that she wants her kids back and there's some policy or way to be able to do that. I'm in favor of programs like home builders and stuff, where they work with the family, even while the mom is still using drugs, to get them to deal with the problem before the kids have to be taken away, and to work with them on the spot, because of taking kids away often removes their own any reason to do anything differently. So you'd have to see what she really wants and then try and get her to that point where she can regain either custody of her kids or whatever her other alternatives are.
There was a reoccurring theme in this client's answers that he kept bringing up family members, his brother and his children and other relatives. And, I'm familiar with, you've done an instrument, this collateral interview piece, and I was wondering where in this model is a family system kind of approach, because that's part of, like, AA has Al-Anon, this, and various other programs have integrate family systems. Where is this?
Yeah. Well, I happened to talk to this client's brother right afterwards. Did another interview. And it became clear while we were doing this that it would be great to get these two brothers together because they have a lot of things to share that I'm not sure they've actually talked to each other about. And that bringing them together, and also with any other family members, could be very helpful, like it would be in any other treatment approach. It's not that harm reduction says, oh, I just work with individuals or something like that. It would obviously work with families, and bringing in family systems theory as one of the modalities to try and help people reduce harmful consequences. It would certainly have a place. There is no therapeutic method, you might say, that harm reduction would rule out. It would just, it's like what you're saying, a very individualized approach. So if it looks as though the family could play a big role, or these brothers could help each other get through the program and do well, then of course we would do that.
Let's assume for a minute that you're preaching to the choir and you've sold us all on the importance of harm reduction as a tool, and we all like it and so forth. One of the problems that I see is that most of us work in contexts of program policies and have to deal with HMOs and a variety of other organizations that don't recognize or accept anything less than total non-drug use, zero tolerance, abstinence, etc., as the outcome of treatment. How would you suggest that counselors approach their program directors, boards of control, HMOs, etc., to try and sell or help them understand the logic, the importance, the utility of the job?
There's an HMO in Seattle, Group Health, which is the largest HMO, and they have surveyed their membership and finding around alcohol that there's a significant proportion of their membership that's drinking at health hazard levels. In other words, could cause hypertension problems. And yet they don't meet the criteria for alcohol dependence. They're not interested in alcohol treatment. So they set up an alcohol harm reduction program for HMO members because they feel that if they can do something now, it's going to save health costs down the line a huge amount. So it's really driven by economic cost-saving ideas, plus putting it more in the context of health promotion. Health promotion and disease prevention is another place where you could talk about harm reduction as being compatible. Now, other more abstinence-based programs are starting to think of harm reduction as what they call recovery readiness training, or in another group, pre-sobriety training. Now, what does that mean? Well, it means, just that's the term implied, some people aren't quite ready for the program because it's not just abstinence as the outcome of the program, it's abstinence as a requirement to get into the program in most cases. So if people aren't quite ready for that, some traditional treatment centers are saying, well, why don't you go ahead and have your harm reduction groups and so forth, and more people will end up coming to our center. And like the Smithers Addiction Treatment Center in New York City works with psychologists who are doing harm reduction to get people ready for their program. They figure that's good consumer relations. Now, there are other programs that try and combine them in the same unit. There's one in Seattle called Stonewall Recovery for gay and lesbian alcohol and drug clients. They have a needle exchange and harm reduction drug use management classes in the back of the place, and in the front of the place they have abstinence-based 12-step programs. You go in a different door. But they're hoping that